Thank you very, very much indeed for such a kind invitation. It's a real honor to be back in Russia and to speak again to this society. The question is important. How much fluid should we give to our acutely ill patients? And
what are the targets? We would like the organs of our patients to be well perfused. So the goal is to have an adequate blood pressure without vasopressors associated with adequate organ perfusion. And we have here 3 windows to look inside the body. One is the skin. How is the skin perfusion? The other one is the kidney. How is urine output? And the third one, of course, in the absence of anesthesia or profound sedation, is the mental status. Is the patient alert, oriented? We would like the lactate levels to be normal, around 1 milliequivalent per liter, or millimole per liter. And we want no excessive tachycardia, right? The problem with fluid administration is edema formation associated with high hydrostatic pressures within the heart and vessels. So we have to navigate between a state of relative hypovolemia with risks of altered tissue perfusion, splanchnic ischemia, multiple organ failure, and the risks of edema. Edema is never good for the organs, whether it is the lungs, the kidneys, the liver, the gut. It's never good. It could also result in multiple organ failure. It's the same thing in sepsis, as we recently reviewed here. In any situation, we have to navigate between relative hypovolemia and excessive fluid administration. And what complicates it further is that we are not just correcting losses. We are not just correcting hypovolemia, because the acutely ill patient is typically vasodilated. There is an inflammatory response due to ischemia or perfusion in case of bleeding, due to sepsis or pancreatitis or other inflammatory states. And we need to play with the Franz-Starling relation in some difficult cases to reach a supranormal cardiac output. So it's not just correcting hypovolemia, as I sometimes hear. It's more complicated than that. So who needs fluid loading clinically? It is those patients who have a problem that may at least be attenuated with fluid administration. It is often arterial hypotension, sometimes tachycardia, sometimes oliguria. Importantly, as we will speak about signs of fluid responsiveness, we will keep in mind that healthy individuals are fluid responsive. So we should not necessarily treat fluid responsiveness. And it's normal to have low cardiac filling pressures. That decreases the risk of edema, so we should not give fluid because the central venous pressure is No, 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 no. Now, on the other hand, the presence of edema does not exclude hypovolemia. In acute heart failure, if I have a massive myocardial infarction right now with cardiogenic shock and that kind of chest x-ray, where would that fluid come from in acute cardiogenic pulmonary edema? It comes from the blood. So what is the volume status in acute cardiogenic shock? Blood volume is reduced. And yet there is edema. So it would be inadequate to limit fluids in an unstable patient having a problem just because there is edema. That's how Michael Pinsky and I recently wrote that piece. It's open access, you can read it on internet. But it says that we should not withhold fluids just because there is edema. We should withhold fluids when there is hypervolemia. But let's be careful about the word fluid overload. What do you mean when you speak about fluid overload? So the concept is that when there is a problem of tissue hypoperfusion, we would like to increase cardiac output. And an easy way when it works is to give fluids. But there is a price to pay. And we do not like to see an increase in cardiac filling pressures, as this can result in edema formation. So optimally, when we give fluids, we would like to have a cardiac output measurement to make sure that the patient is a responder, that cardiac output increases, and not that the patient does not benefit. Now we have a number of techniques available to measure cardiac output. I will not review them all, but for the risks, a central venous catheter is necessary to measure a cardiac filling pressure, to evaluate the risks of edema. Again, we would not like the central venous pressure or the left-sided filling pressures to increase, but it may be a price to pay. Exactly as when we go to a restaurant. We would like to have good food, good drinks, atmosphere, but there will be a price to pay. There will be a bill at the end of the meal. So we should be careful. We should not order an additional dish if we do not use it. So this should be titrated. And that's how working by formula does not work. It works for baseline fluid replacement during surgery or in the perioperative period. Baseline, but not for adaptation, as this will have to be individualized. Did you read that paper published recently in the New England Journal of Medicine? Randomizing patients for major abdominal surgery for less fluids or more fluids by formula. Does it make sense? Of course. When you limit fluids too much, there is more renal failure. And it's not surprising that there are more infections. You are inducing hypoperfusion. What kind of study is this? What we knew before the study is that fluid administration must be individualized, guided by appropriate monitoring devices. Fluid restriction may result in renal failure. What we know after the study, exactly the same thing. That does not help. People seem to miss the point that we need to individualize therapy, and here the time must be taken into account. In which phase are we? SOSD. There is a first salvage phase. If the patient is acutely bleeding, if the patient is obviously hypovolemic. We do not have many monitoring systems initially. But as soon as possible, we will go into an optimization phase where we will have to monitor the patient, and then a stabilization phase before the patient eliminates the fluid. Because all patients who are acutely ill will develop some degree of edema following trauma, surgery, sepsis, whatever. So for the initial fluid resuscitation, we just pour fluid, okay. But then in the optimization phase, as we reviewed here, in the British Journal of Anesthesia, we could use initially echocardiographic techniques, but quickly central venous pressure monitoring with SCVO2 monitoring, cardiac output monitoring, signs of fluid hyporesponsiveness, and fluid shock. Now, some people today say no to central venous pressure, but they say no to everything. No, we don't need this, no transfusion, no fluid, no saline, no early on-directed therapy, no. Well, it's true that the central venous pressure will not tell us if the patient needs fluid, but it's the same for a given blood pressure, heart rate, cardiac output, urine output, SCVO2, lactate level. The central venous pressure is a safety index. And of course it is influenced by different elements, including right heart function, left heart function, pulmonary function, intrathoracic pressure. If you like, we just published this paper, 10 answers to 10 questions about the central venous pressure. It's also open access. You can read it on internet for free. What we know is that many patients with a low central venous pressure will respond to fluids if there is a problem. We know that. But importantly, a high central venous pressure does not exclude the possibility that fluids will help the patient. So we should never withhold fluids only because a central venous pressure is increased. But it's already good to know that there is not much risk in giving fluid when the central venous pressure is low. We say there is room for fluid. because the risk of development of edema is relatively low. The patients are somewhere there in the Frank-Starling relation between cardiac output and a cardiac filling pressure. And every patient is on one of these lines. So it's true that at some point, we do not know if the patient will respond to fluids or not. We should not forget that patients with chronic lung disease may have a high central venous pressure to start with, and yet they may have a relative hypovolemia. Patients with ARDS, same thing. Do not forget that any cause of pulmonary hypertension will result in a high central venous pressure. And it doesn't mean that the left-sided filling pressures are high, of course. It could be a right heart problem. That's how in this classical paper published more than 10 years ago, we say it's a misconception to withhold fluids because the central venous pressure is elevated. So, if we want to try fluid administration, we should do a fluid challenge. It's not the same as fluid loading. No, 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 no. As we wrote in this paper, a fluid bolus is the rapid administration of some fluids. A fluid challenge is a test. A test where you evaluate the effect of a modest volume in patients. So how many patients will respond? It depends on your population. If you do fluid challenge very frequently, or in some extreme cases, the percentages will vary. Of course. It could be 50%, it could be more, it could be less. In septic patients, with the surviving sepsis campaign, we recommend first that a fluid challenge technique is applied where fluid administration is continued as long as hemodynamic factors continue to improve. We don't need a large study on this. It's a best practice statement. And in children, more recently, this consensus guidelines recommend first to evaluate the patient, heart rate, pulses, level of consciousness, urine output, and then to monitor filling pressures to optimize preload and thus cardiac output. And they nicely say that if the increase in central venous pressure is too high in relation to the increase in arterial pressure, stop, because the benefit is limited. So when you do a fluid challenge, there are 4 elements to define: the type of fluids, of course, the rate of infusion, something like 200 cc's in 10 minutes, the clinical objective, blood pressure, heart rate, and the safety limits. Some people say, oh, you give too much fluid, you give it. No. 100, 200 cc's in 5 to 10 minutes. 100, 200 cc's in 5 to 10 minutes. You could perhaps even do a mini fluid challenge with 100 cc's in 1 minute. This has been proposed by different investigators. It may be a bit too fast because we may have a positive response in every individual. However, as Dr. Hayes showed recently, a mini fluid challenge could predict fluid responsiveness in the operating room. It's true that in the operating room, you may not have the time to do the test in 10 minutes. So in the OR, you could give a short fluid bolus. But in the perioperative period, it's better to have a longer fluid administration, because a too short fluid administration may result in a positive response in virtually any individual. So you will continue. And if you give it too slowly, the effect may be too slow to visualize anything. If you give 100 cc's in half an hour, or there may be other influences of cardiac output. So cardiac output may fluctuate, and you don't know if it's due to fluids or something else. That's how the experience showed that 100 to 200 cc's in about 10 minutes is probably the best way to go. But during that time, in the perioperative period, we do not do anything else to the patient. So I could give an example here. Let's move to the second example. If we are together at the bedside of a patient who has a heart rate of 120 per minute, someone may say, he's perhaps hypovolemic. Regardless of the CVP value, doesn't tell you much about the volume stages. But someone else may say, it's just a fever. And someone else may say, maybe there is a little bit of pain. Someone else may say, maybe it's anemia. So what shall we do? Shall we increase a little bit the amount of fluids over the next 24 hours? Agreed? No. Because if there is hypovolemia, you will correct it too slowly. So what you could do is to propose a fluid challenge, let's say with saline solution, 500 cc's in 20 minutes, but we could stop at 10 minutes if we see that there is already a response. In this case, we could see a reduction in heart rate, and we have the answer within 10-20 minutes. Or if there is no decrease in heart rate, but an increase in central venous pressure, we could say there was no hypovolemic component. We checked. So it's a rapid evaluation at the bedside. We could look at just heart rate, as in this example. In some cases of pure hypovolemia, we could see the increase in arterial pressure. Although in patients who are dilated, like in after polytrauma, after major surgery, in sepsis, sometimes cardiac output may increase, but not so much the blood pressure. So that's a situation where it may be better to monitor cardiac output. During surgery, I'm not so sure that we need it during surgery. But in the perioperative period, that's how it is. Always monitor the patient's response, MIA, measure, interpret, apply. If you measure something, but if you do not interpret, if you do not apply, it will not help. That's how I like the challenges, the fluid challenge, a little bit of the dobutamine challenge, in patients who are vasoconstricted, a few micrograms per kilogram per minute of dobutamine, that's it! vasopressor challenge in the patient who is a bit hypotensive. Let's try to increase a little bit the doses of noradrenaline. Now, importantly, the fluid challenge has for principal aim to stop when the patient does not respond. Stop when the patient does not respond. You may use, in some cases, signs of fluid responsiveness before you start any fluid challenge. When it's applicable, and that is primarily in patients who are mechanically ventilated, so that there are transient changes in intrathoracic pressure that could be translated into a change in arterial pressure, indicating that the patient is still on the ascending limb of the French-Starling relationship. When I say a change in arterial pressure, it's really the pulse pressure variation that we should look at, and we will speak more about it later. Or we could use the stroke volume variation with some monitoring techniques. But that's true in the operating room when the patient is mechanically ventilated without spontaneously breathing movements, and provided, of course, that there are no significant arrhythmias. And, of course, the signal is limited now that we use smaller tidal volumes than earlier. It's not perfect, but in the operating room, that should work. Outside the operating room, we no longer sedate our patients, except in very severe areas. Otherwise, today, we have abundant sedation. We treat pain with analgesia, of course, but the patient can trigger the respirator. And of course, there is a gray zone. It's not always that precise. We could potentially do a little test with a positive by increasing the end, by doing an end expiratory occlusion test, or potentially, I think my microphone will be up here, or potentially by transiently increase the tidal volume. Clearly, single measurement of vena cava collapsibility is suboptimal, especially if you go to the inferior vena cava. There, it's not very reliable. But even when you go by transesophageal echo, looking at the superior vena cava, doesn't work so well even in sedated patients. Outside the operating room, you could do a passive leg raising test. A passive leg raising test makes sense physiologically, but it is not so easy to perform. It makes sense because it's some kind of internal fluid challenge without having to give the fluid bolus. But it's a very transient change in stroke volume. Again, this is open access, you can read it. But the important factor is that we should not just look at blood pressure. Does it work? No. You should not look only at blood pressure, thank you very much. We should look at a measurement of stroke volume, and it will be a very transient phenomenon. So, at the end, The fluid challenge technique is the baby bottle challenge. When a baby cries, you take a baby bottle and you try. And if the baby stops crying, that means there was a volume deficit. But nothing is perfect. And too often people do not do the fluid challenge properly. That's how I was pleased to take my time to explain it. Pulse pressure variation, stroke volume variation. In the operating room, it's okay. Echocardiography is perhaps a little bit overemphasized, and the passive leg raising is not as easy as it appears. So, at some point, we need to identify the stabilization phase and stop giving fluids then. People miss that. And then indeed, the patient is full of edema. And excessive edema can be associated with worse outcomes. That's true in sepsis and other diseases. Read this paper from the large ICON study. There are Russian centers in it. Maybe you participated. 10,000 patients. And clearly, if the fluid balance remains positive over 48, 72 hours, then the mortality increases, all other elements being taken into account. So, we will have to go then into a de-escalation phase, wherein the patient will eliminate the edema fluid, and maybe then we will have to give a bit of diuretics, then not before. It would be harmful to give diuretics if we have not reached that phase. So I'm reaching my conclusion, or rather a summary, which is that we need to identify first a clinical problem. But there is no clinical problem that will tell us for sure that this patient will need fluid. Unless there are obvious fluid losses. But it's not any of these clinical elements that will tell us for sure that the patient needs fluid. And ultimately, it's the test that counts. In some cases, especially during surgery, we can look at signs of fluid responsiveness in anesthetized patients. So, if the filling pressures are very low, no problem, no risk of edema. But very often, the cardiac filling pressures are not so low. And again, if we are in the perfect conditions where we can look at signs of fluid responsiveness, that's fine. Otherwise, we have to do a fluid challenge, usually external. We could try an internal fluid challenge by passive leg raising, but it's not very easily done. Do we need a measurement of cardiac output? Not always. Sometimes it's better. Sometimes we can do without it if there is a clear blood pressure response or a response in heart rate or later in urine output. But the concept remains that a fluid administration, we hope for an increase in cardiac output. That will result in an improvement in tissue perfusion. And we do not like to see an increase in cardiac filling pressures, an increase in the venous pressures in the system. So we also need to consider when to stop.
either when there is a resolution of the problem or when there is an excessive risk-benefit ratio. And for this, we need to monitor the patient's response. So the rule number one, the presence of edema does not exclude an insufficient blood volume. It's not just edema. We give additional fluids only when there is an identified reason for it. If the patient is possibly hypovolemic, we should not increase the maintenance fluids. We should give fluid boluses to appreciate the effect of it and correct hypovolemia rapidly. We should always monitor the patient's response, and if fluid administration does not benefit the patient, we must stop immediately. So, identify the problem, evaluate the risk-benefit ratio, and monitor the patient's response. Thank you very much.